Hello, everyone. Next slide, please, Wendy. Hello, everyone. My name is Khadija Dantata, and I'll be your host for today's event. Thank you for joining us. As we all know, fatigue and pain are among the most difficult symptoms affecting people living with lupus. I'm very excited to have amazing speakers who will educate us on this important topic, including management strategies. Next, please. As you can all see, we have a packed agenda today. We're so honored to have Dr. Clauw and Dr. Birnbaum. Today, Dr. Clauw will educate us on pain in SLE, and Dr. Birnbaum will highlight management strategies for fatigue in lupus patients. A portion of our event will be dedicated to answering your questions, and we'll wrap up with closing remarks. Next, please. I'd like to highlight some housekeeping items. If you have a general question that you would wish to submit, you can submit that using the Q&A poll at the bottom of your screen. You can also choose to submit your question anonymously. And a gentle reminder that all the content that is shared in this event is strictly for educational or informational purposes only. We highly recommend that you consult with your healthcare providers for any medical or treatment advice. Great news. This webinar will be recorded and it will be shared with you all along with other educational resources and a survey for your feedback on this event. Next, please. So we'll have our first poll question now. So our question is, have you or your loved one with lupus experienced pain or fatigue related to lupus? The options are yes, no, or I'm not sure. I'll give us a moment to put in our answers. And I'll give us more seconds before we get our poll results back. Wow, this makes it a very important topic, and I'm very glad that we're discussing this very important topic, as 94% of the attendees have experienced pain or fatigue related to lupus. Next, please. Next, please. Next slide. So our vision at the Lupus Foundation of America is a life free from lupus. We are dedicated to improving the lives of people living with lupus through education, research, support, and advocacy. Today, many people living with lupus are living healthier and longer lives, and we believe Lupus Foundation of America has played a tremendous role in this development. Next, please. Our pillars at the Lupus Foundation are three: advocacy, care and support for people affected by lupus, and research. We have redefined lupus research to expand our efforts beyond just funding research and grants. We are engaging all stakeholders to identify barriers that stand in the way of progress and setting a course to overcome them. And we do this while providing caring support for people affected by this devastating disease and leading advocacy efforts to bring more funding for research and services. Next, please. People with lupus represent the heart and soul of our organization. You are the central focus of everything we do. You are a constant reminder of our mission's urgency and serve to motivate us to continue this fight. Because of you, we are motivated to work harder and faster to bring lupus under control so that everyone living with this disease can have a life free from lupus. Next, please. I'd like to highlight some of our programs and services. So we have the health education specialists who are here with us tonight. Our health education specialists are trained to provide educational resources, support, and non-medical counseling to people living with lupus, their families, and caregivers to help them navigate life living with lupus. We have 2 bilingual health education specialists, and you can contact our health education specialists via email or phone call. Today, our health education specialists are here with us to help you to help answer your questions at the Q&A section. Next, please. Another program we have is the Take Charge. This is a 12-week email series designed for people living with lupus, including people that are recently diagnosed. When you sign up for the Take Charge email series, you'll receive tips and resources from our health educators on how to take charge of your health. This includes simple tips like how to make the best out of your doctor's visit, how to track your symptoms, and so much more. Next, please. Self is a free downloadable mobile app. The Self program is your virtual coach to help you build and enhance skills in 4 pillars of lupus self-management. This includes managing your symptoms, managing stress, managing medications, and working with your healthcare team. No matter how long you've been living with lupus, Self includes tips and tools designed to help you manage your disease. Next, please. We have so many ways you can get involved with the Lupus Foundation of America. We're excited to let you know that we are having the National Advocacy Summit. This is where lupus advocates unite to learn, connect, and raise their voice at the Capitol Hill in support of federally funded lupus research and education programs. Registration for this program closes April 10th. However, there will be live stream registration for people who are unable to attend in person. Next, please. We have the Game On to End Lupus, popularly known as GOTEL, the Lupus Foundation of America's Games On to End Lupus. This unites streamers from around the world as they play video games and get creative while using their platform to help end lupus. When you stream, you'll be helping to raise money for lupus research, increase awareness of the disease, and rally the public to support for people who suffer from this brutal impact of lupus. Next. We're very excited for Lupus Awareness Month, which is just around the corner. This is an opportunity for everyone to join the nationwide effort to raise awareness and funds for lupus research and education programs. You can help make lupus visible this May. There are many ways you can get involved. You can either host a fundraiser, an awareness event in your community, share your story, or spread the news or word on social media, or participate in Put On Purple Day. Put On Purple Day is a day when everyone gets their purple on to show their support for all people impacted by this disease. We'll also have a number of tools to help you spread the word and educate others about lupus. So be on the lookout for our Lupus Awareness Month toolkit. Next, please. So we'll have our next poll question. This is a true or false question. Next, please. So is muscle and joint pain, is muscle and joint pain not caused by lupus? True or false? I'll give us a moment to put in our answers. Few seconds to wrap up. 91% said false. Muscle and joint pain is not necessarily caused by lupus. We'll hear more about that from our speakers tonight. So before I turn it to Dr. Clauw, I would like to briefly introduce Dr. Clauw to everyone. Dr. Daniel Clauw is a professor of anesthesiology, medicine, rheumatology, and psychiatry at the University of Michigan. He serves as the director of the Chronic Pain and Fatigue Research Center until 2009. He also served as the first associate dean for clinical and translational research within University of Michigan Medical School and PI of the University of Michigan Clinical and Translational Sciences Award, CTSA. He attended the University of Michigan for both undergraduate and medical school studies, and then completed his internal medicine residency and rheumatology fellowship at Georgetown University. He joined the faculty of Georgetown University in 1990, and while there, he founded the Georgetown Chronic Pain and Fatigue Research Center and served as the division chief of rheumatology, immunology, and allergy, and vice chair of the Department of Medicine. Since moving to University of Michigan in 2001, Dr. Clauw has continued his commitment to the clinical care and research into overlapping conditions such as fibromyalgia, Gulf War illnesses, and interstitial cystitis, just to name a few. Having become an internationally known expert in chronic pain, and especially the central nervous system contributions to chronic pain states, performing past or ongoing work in conditions such as low back pain, osteoarthritis, vulvodynia, endometriosis, irritable bowel syndrome, and temporomandibular joint disorder. Thank you, Dr. Clauw. It is an honor to have you tonight with us.
Thanks so much for having me. Next slide, please. And you can go to the next slide. And then one more. So this is a little bit of an outline of my talk. First, I'm going to define what probably are new terms to many of you. You heard that I was trained clinically as a rheumatologist, but for the last 20 or 30 years, I've really been more of a pain researcher. And some of these terms are really coming from the field of pain. After I talk about some of the new terms and define some of these things, I'll talk about what we know about pain in lupus and then some about treatment implications. So first of all, the new terms. There's a term that we didn't particularly like the term when it was introduced, but we have to live with it. It's called nociplastic pain. And that's the kind of pain that I'm going to talk a lot about. That's pain that's coming more so from the brain and the central nervous system than because there's some damage or inflammation in the area of the body where you're experiencing pain. So again, the conditions that many of you would know about that are like this are conditions like fibromyalgia, headache, where there's no damage or inflammation in your head when you have a headache, phantom limb pain, but there's a lot of very common pain conditions that are called chronic overlapping pain conditions, where this is also the case, where these same mechanisms, these nociplastic mechanisms that are operative in fibromyalgia are really the main mechanisms in things, for example, like low back pain. Primary pain is another term that is really similar to this. Primary pain means that pain is the primary problem rather than it being due to something like lupus or rheumatoid arthritis or osteoarthritis. And so again, you're aware that some people with conditions like fibromyalgia just have fibromyalgia. And when I say that, I don't mean just have fibromyalgia because it's not a condition that you'd choose to have. But we also know that that same kind of pain that occurs in fibromyalgia occurs commonly in people with any autoimmune disorders, and it probably occurs in at least 30 or 40% of patients with lupus, with rheumatoid arthritis, with ankylosing spondylitis. One of the new terms that's been introduced by the Duke group recently is type 1 versus type 2 lupus. And type 1 lupus means that the symptoms that you're having are due to active inflammation, active lupus, whereas the type 2 is really this the concurrence of fibromyalgia-like pain or of nociplastic pain. Next slide. So why don't you advance one more? Okay, so the first definition for fibromyalgia about 30 or so years ago required that people had widespread pain and they had a certain number of tender points, and you had to push with 9 pounds of pressure in different areas of the body and count how many tender points people had. And that definition was useful in that it helps standardize research into conditions like fibromyalgia. But one of the things that wasn't good about it is women are a lot more tender than men. And so it made us think that almost all people that had fibromyalgia were women. And so now advance to the rest of the slide. And now what we know over 30 or so years is that as we've understood the kind of pain in fibromyalgia better, this nociplastic pain, this kind of pain has been recognized as a third mechanism of pain that we didn't really know about until, again, 20 or 30 years or so ago. People used to think that most people with fibromyalgia just had severe psychological problems and there was nothing wrong with them. It was all in their head. What we're realizing it is, a lot of it is in their head, but it's in their brain. And that this type of pain that's often accompanied by fatigue, sleep problems, memory problems, mood problems, occurs very commonly in individuals with conditions like fibromyalgia. But again, the same kind of pain is often superimposed upon conditions like lupus. Next slide. And so these are the three pain mechanisms. Nociceptive pain means there's some sort of damage or inflammation. You hit your thumb with a hammer, it's supposed to hurt. That kind of pain is nociceptive pain. Neuropathic pain is that there's either a nerve is pinched or a nerve is damaged. That's nerve pain. But this third column, it really wasn't until the last 10 to 20 years that we began to understand this third mechanism of pain, where fibromyalgia is sort of the poster child, but there's a lot of different pain conditions, these nociplastic pain conditions, where this is the primary mechanism. This would include fibromyalgia, irritable bowel, headache, temporomandibular disorder, interstitial cystitis. And next slide. And this new term, nociplastic pain, is again a term that's being used more and more by pain researchers, especially. And we know that this kind of pain, that the fundamental problem is that the brain and the central nervous system are, it's almost as if the amplifier is set too high, because these individuals are not just more sensitive to pain, but they're more bothered by bright lights, loud noises, odors. And that we see that when people have this kind of pain, they often have fatigue, sleep problems, memory problems, mood problems, in addition to the pain. And so sometimes one of the ways that we can tell if you're having this kind of pain rather than lupus pain is sort of the company that it keeps. If when you have a flare of your pain, you also have a lot of sleep problems and fatigue and memory problems, it may very well be that you're really having this other kind of pain that occurs commonly in any autoimmune disease. And again, we know also occurs commonly in lupus. Next slide. So these conditions, next slide, that where these same mechanisms in advance that are operative in fibromyalgia are primarily thought to be the main mechanism in headache, the main mechanism in irritable bowel, the main mechanism of what used to be called interstitial cystitis, or now bladder pain syndrome, low back pain, endometriosis. In some individuals, they have these same core symptoms of fatigue, sleep problems, and memory problems, but the pain isn't as bad, and that would be more sort of a chronic fatigue syndrome kind of picture rather than one of these pain conditions. And advance one more, please. And then down at the bottom, we know that all these same mechanisms that are front and center in conditions like fibromyalgia are often there in the background in conditions like lupus or rheumatoid arthritis or autoimmune diseases. Next slide. And so one of the analogies that I've been using for a long time that's still very apt is that the amount of pain that someone has is like the loudness of an electric guitar. And there's two ways you can make an electric guitar louder. You can either strum the strings harder or you can turn up the amplifier. So advance a little bit. So imagine two different people, one with a normal knee X-ray on the left and one with a really abnormal knee X-ray on the right. You would think that the person on the right is always going to have a lot more pain than the person on the left. But that information from the two knees, advance a little bit more, comes up from the nerves in the knees, up through the spinal cord and up to the brain. And some people have a very low amplifier setting such that they can have a knee like the one on the right, and not have any pain whatsoever. And other people have a high amplifier setting in that they don't have to even have anything wrong with their knee. They can have pain, and this would be someone with a condition like fibromyalgia. They can have pain really because their amplifier is set too high rather than that there's something wrong out in their knee. And again, what we learn now is that this amplifier, when people have a high amplifier for pain, they also often have a high amplifier for how bright a light is, how loud a noise is, because the same brain regions are involved in processing all of this different type of sensory information. Next slide. Fred Wolf was a rheumatologist. He's passed away. He was a big leader in fibromyalgia, and he coined the term fibromyalgia-ness to say that a lot of people don't necessarily have fibromyalgia per se, but they have a little bit or a moderate amount of fibromyalgia. They might not meet criteria for fibromyalgia, and this certainly happens in the general population as well as in people with autoimmune diseases. Some people with autoimmune diseases with like lupus might not really have any superimposed fibromyalgia. Some people might have a little bit, and some people might have a lot, where the fibromyalgia type symptoms are actually driving their pain and their fatigue more so than active lupus at some points during the course of their disease. Next slide. And so these are the new fibromyalgia criteria. If you want to like take this measure really quickly yourself to see what your fibromyalgia score is, you can. You check how many different regions of the body you have pain in on the left. There's 19 different sites, and you just add up how many different sites that you have pain. The more regions of pain that you have, the more likely it's an amplifier problem, because if the amplifier was set too high, you would really have pain almost anywhere. And then on the right side of this, we ask people about fatigue, memory problems, and sleep disturbance. And if you have none of that, you get a 0. If you have mild, you get a 1. If you have moderate, you get a 2. And if you have severe, you get a 3. So you can get a 3 for severe fatigue, a 3 for severe memory problems, a 3 for severe sleep problems. And then you get 1 point each for the symptoms down at the bottom for irritable bowel, depression, or headache. And this can be scored from 0 to 31. And the current criteria for fibromyalgia are that someone has a score of 13 or higher by adding up 0 to 19 points from the left side and the 0 to 12 points from the right side. But again, what I want to emphasize is if you give yourself that questionnaire and you score a 7 or an 8, you might not meet criteria for fibromyalgia, but you might have some of the same mechanisms that are playing a role in fibromyalgia playing a role in your pain. Next slide. And so again, we write a lot of articles about this. Next slide. These are some recent review articles that have come out talking about this. These are just a summary of some of what's going on in the brain of people with these conditions. There's different brain networks that are too connected to each other. And we can see that people are really more sensitive to any type of sensory stimuli, not just painful stimuli. Again, all sorts, and some kind of sensory stimuli are feeling bloated or feeling like your bladder is full. It's surprising how many different symptoms throughout the body can be caused by an increase in sensory sensitivity. Next slide. And we also know that different things can trigger a worsening of this kind of nociplastic pain or fibromyalgia. The reason I studied the Gulf War illness is we realized that there was an epidemic of this in the people that were deployed to the first Gulf War. This can happen after trauma, it can happen after motor vehicle accidents, after infections. And having a condition like lupus is almost like all of this in one. It's a lot of different trauma and stressors that occurs as a part of having a chronic autoimmune disease like lupus. And we think that's why so many people with autoimmune diseases develop comorbid fibromyalgia or comorbid nociplastic pain. Next slide. And there's two different forms of this. Top down are people that just, if you will, again, I'm not making light of it, have fibromyalgia or headache or low back pain. They just really have the pain conditions, these primary pain conditions. But the bottom up are people with conditions like lupus or rheumatoid arthritis, where we know there is some inflammation in the periphery. And then above and beyond that, the inflammation can drive this central sensitization or this nociplastic pain. Next slide. And so what's known about pain in SLE? Lupus hasn't been as well studied with respect to the pain mechanisms as other autoimmune diseases like rheumatoid arthritis or even the spondyloarthropathies. But there's some data suggesting that this nociplastic pain or fibromyalgia-like pain is a big problem in lupus. Next slide. I think you go back one. You might have gone past one. Oops. Okay, I'm sorry. Yeah, there. Okay. Again, this is the group from Duke is coming out with these new terms, type 1 and type 2 lupus. Type 2 lupus is really where people with lupus have these nociplastic features that I've been talking about. Next slide. This is a study, and a couple of these studies were done by the people at Stanford that show that in a lot of people with lupus, they have a lot of pain and fatigue and memory problems and sleep disturbance, but it doesn't seem to be related well to the disease activity, to the active inflammation in lupus. Next slide. And again, this is yet another where it was really looking at, and the conclusion here was that disease activity and organ damage explained about a third of the variance in pain in people with lupus, but about 2/3 of it really wasn't explained by disease activity. And again, we think that a lot of this is really explained by this nociplastic pain. Next slide. So what are the treatment implications? Next slide. First is you have to use a different set of drugs. Opioids don't work for this kind of pain. Narcotic analgesics don't work. Non-steroidal anti-inflammatory drugs don't work. And these are the drugs that do preferentially work. I'm not going to go through medications, but the ones at the top of the screen are the drugs that seem to work best for this kind of pain that we see in conditions like fibromyalgia. But again, a point of emphasis is that opioids don't seem to work, nor do non-steroidal anti-inflammatory drugs. And those are sort of mainstays of treatment of pain, of other types of pain. Next slide. Again, opioids don't work, so don't go there if you think you have this kind of pain. It might actually make your pain worse by taking an opioid rather than not improving your pain. Next slide. And then we're really heavily use non-drug therapies. Want to advance to the end of this slide in treating this kind of pain, because regardless of what causes your pain causes you to be stressed, it causes you to be inactive, to sleep poor, to gain weight, to develop bad habits, and keep advancing, please. Uh, and then those feed up to the brain. And so, and we can use drugs to treat some of these symptoms, but we really have to aggressively use non-drug therapies, getting people moving again, getting people sleeping again, managing stress, and trying to get them access to some of these non-drug therapies that can really be very helpful to treat this kind of pain. Next slide. And these, when I wrote a review article in the journal JAMA in 2014, this is what the evidence looked like. But it just keeps increasing and increasing. Just to advance one more slide. Now there's 5 different types of cognitive behavioral therapy. You can get cognitive behavioral therapy for pain. You can get cognitive behavioral therapy for insomnia. For if people have had a lot of different trauma, there's different specific types of cognitive behavioral therapy, and all of those things under modest evidence, strength training, hypnotherapy, biofeedback, yoga, Tai Chi, all of these non-drug therapies we're learning are really the mainstay of treating this kind of pain that we see in conditions like fibromyalgia. Next slide. We might even be using diet and nutrition. We've shown that caloric restriction or very low calorie diets can also help treat this kind of pain. Next slide. And then our group spends a lot of time trying to develop different self-management tools for patients. We developed a website that's being widely tested in different pain conditions called Pain Guide, but advance one. Next slide. We worked with Lupus Warriors, go back one, please, to develop a version of this specifically for individuals with lupus. You see the URL of the website up there. We don't get any money for this. This is just something that we put out there. And it really, go to the next slide, just give you an idea. It gives people access to all of these different types of non-drug therapies, acupressure, goal setting, nutrition, pacing, all of these things. If you want to work on them, there's specific then chapters in the website, workbooks that you can use. But these are really meant to be, this website's really meant to be a tool that patients with conditions like lupus can use to try to get access to some of these non-drug therapies that are often not reimbursed by insurance and not yet readily available for patients to use. So I think that's done. Next slide. Yep, I'm done. Thank you.
Thank you so much, Dr. Clauw, for sharing such valuable information. Thank you. And this brings us to our third poll. And the question is, have you discussed your pain and fatigue with your doctor? The options are yes, no, I tried but wasn't successful, not applicable. And we'll wait while you put your answers in. Few seconds to wrap it up. Wow. 77% of you have discussed your pain and fatigue with your doctor. This is very, very important to discuss any symptoms you're experiencing with your healthcare provider. And before I pass it to Dr. Birnbaum, I'd like to briefly introduce him to us all. So Dr. Birnbaum has been a practicing rheumatologist for 20 years. He is the author of the book Living Well with Autoimmune Diseases, a rheumatologist's guide to taking charge of your health. This book provides strategies to improve care of patients with lupus and other autoimmune diseases. He received his undergraduate degree from Princeton University and received his medical degree from Columbia Vagelos College of Physicians and Surgeons. Dr. Birnbaum is the only physician in this country who is trained as an internist, a neurologist, and as a rheumatologist. He completed his rheumatology fellowship at Johns Hopkins University School of Medicine. He has been privileged to speak at patient conferences as well as physician conferences. He actually prefers giving talks directly to patients. He moved to the University of Pittsburgh Medical Center in 2020 and is currently an associate professor in the Division of Rheumatology. He now cares for lupus patients who have many different complications, including rashes, arthritis, heart, lung, and kidney diseases. He serves as a division chief of rheumatology at UPMC Mercy Hospital. His primary role is a clinician educator. He has taught and mentored more than 100 medical students, residents, and fellows. He has a passion for many sports, including basketball, swimming, and running. He particularly enjoys sharing these activities with his family. He lives in Wexford, Pennsylvania, with his wife and 3 children. Thank you, Dr. Birnbaum. We're very excited to have you tonight.
No, thank you. It's a pleasure to be here. And I want to thank the Lupus Foundation for the opportunity and privilege of giving this talk. I'm really excited and pumped for this management discussion because by the end of the talk, I hope that we'll explore together that a lot of the management options that you have for fatigue include strategies other than medications. So I think that even starting tonight, when you log off this talk, you can start hopefully incorporating these strategies and start getting you down your journey towards better management of fatigue. So next slide, please. So I have no pertinent disclosures. Next slide, please. So here are the overall objectives of this talk. First, we're going to consider how you can identify fatigue so you can better describe it to your physicians. The second objective, we're going to consider how fatigue can also stem from causes other than lupus. Number 3, we're going to, go back. Thank you. We're going to understand how fatigue actually is not associated with active inflammation in a lot of lupus patients. Number 4, we're going to get to the point where we can help you develop a personalized treatment plan for your fatigue. And then finally, we're going to explore some really fascinating implications for how these facets in lupus can be relevant for managing fatigue and other autoimmune disorders. Next slide, please. So here are some really striking statistics. So fatigue is often reported as the most common symptom in lupus patients, and it's been reported in occurring about 90% of patients. And so not only that, in addition, about 50% of lupus patients feel that fatigue is the most disabling symptom that they experience. But despite this, patients sometimes feel that it's difficult to describe exactly how the fatigue experienced them to their physicians. Next slide, please. So how can I evaluate and define fatigue in lupus patients? How I evaluate it? Next slide, please. So in a sense, when you ask about other lupus symptoms, simple yes or no responses might be sufficient. Do you have oral ulcers? Do you have hair loss? But in contrast, asking if you have fatigue, it really should only be viewed as a starting point, because fatigue includes a wide variety of symptoms and really differs from between individuals. And that means that if you're a lupus patient with fatigue, you experience fatigue differently than any other lupus patient on the planet. So really, questions should focus on how fatigue impairs your day-to-day quality of life as an individual. So to start with, questions should evaluate for what is called the mental as well as the physical features of fatigue. Next slide, please. So we'll go one more slide, please. So here's some questions which can explore the physical components of your fatigue. So does fatigue prevent you from starting certain tasks and activities? Does fatigue make it difficult to carry out job responsibilities? Does fatigue prevent you from activities that bring you enjoyment? Does fatigue make it difficult for you to exercise? How many hours of sleep do you get on a nightly basis? And do you feel refreshed when you wake up? Next slide, please. Some questions which explore the mental components of fatigue. So does fatigue make it difficult to carry on a conversation? Does fatigue make it difficult to remember things? Does fatigue cause you to feel sad, hopeless, or frustrated? And does fatigue make it difficult to remember your medications? Next slide, please. So here's some take-home points about management and starting management of fatigue in lupus patients. So as I mentioned, each lupus patient experiences fatigue in many different and individualized ways. And it's really asking about fatigue is so much more than a yes or no experience. And as these questions suggested, we really need to consider the physical and mental components of fatigue and how this impairs your day-to-day quality of life. So the take-home message is, as physicians, we really need to make sure we're listening to your voice, and we need to prize how you describe symptoms in such unique and individualized ways. Next slide, please. So it's really important to consider how I identify non-lupus causes of fatigue. Next slide, please. And this is because a lot of fatigue in lupus patients stems from non-lupus cause. So here are 5 non-lupus causes to consider. So number 1 is hypothyroidism. This should be tested in all lupus patients who have fatigue. So we have a thyroid gland in our neck. It secretes thyroid hormones. And when the thyroid gland is damaged, such as Hashimoto's thyroiditis, there could be fatigue along with other symptoms. And that could be cold intolerance, pain, constipation, dry skin, and low heart rate. Number 2 is vitamin deficiency, vitamin D deficiency. All lupus patients who have fatigue should be checked for vitamin D deficiency. Now, vitamin D is absorbed from the sunlight. So it used to be thought that vitamin D deficiency should be checked primarily in lupus patients who don't have enough access to the sun. So for example, a lupus patient who needs to avoid excess sunlight because of rash. But now we recognize that all lupus patients with fatigue should be checked for vitamin D deficiency. The third non-lupus cause that's often overlooked, it's something called chronic adrenal insufficiency. So the adrenal gland in our body, it secretes a certain baseline level of steroids. It enables us to function and feel well. Now, what happens is when patients are treated with steroids at a certain dose for a sustained period of time, that causes the adrenal gland to actually shrink and become atrophied. And so when the steroid is tapered completely to off, those patients can have a lot of different symptoms. So it can include pain, nausea, vomiting, muscle weakness. And the key is these symptoms developing while your prednisone is being tapered. Number 4, always consider potential medications that are contributing to fatigue. And these are medications that could use to treat anxiety, allergies, pain. And these medications need to be explored to see if they're causing fatigue. And number 5 is anemia. And so anemia can be caused from lupus, but I think that iron deficiency anemia is really an overlooked cause of fatigue in lupus patients. And as we'll see in the next slide, it's not only important to identify that you have oh, go back 1 second. Yeah, so it's important to ask why you have iron deficiency anemia. So next slide, please. So what about cancer? I want to emphasize right at the forefront that this is a very, very infrequent cause of fatigue in lupus patients. So I don't want to needlessly scare anybody. For the most part, as for non-lupus patients, you should just make sure you're up to date on breast cancer screening, colorectal, cervical, lung, and possibly prostate cancer if you would discuss it with your physician. But at certain times, additional screening for cancer might be necessary. For example, if you have the fatigues associated with a lot of weight loss, drenching night sweats, elevated blood markers of inflammation that are not due to lupus, or abnormal LAMs such as an iron deficiency anemia. All patients need to be checked for colon cancer by a colonoscopy. And then beyond this, it's an individualized decision between you and your physicians need to decide when additional studies might be necessary, such as a CAT scan of the chest, abdomen, or pelvis. Next slide, please. So this has been covered before in the last talk. I'm just going to add my own neophyte comments here. So fibromyalgia is a chronic widespread pain disorder. It could be associated with brain fog and unrefreshed sleep. And then patients also experience what we call distressing somatic symptoms without a cause. And examples include unexplained migraines and ringing in the ears and irritable bowel disease. Next slide, please. So the take-home point of this second part of the talk is that fatigue can often stem from non-lupus causes. So in all cases, your physician needs to comprehensively search for non-lupus causes of your fatigue. And this is because identification of non-lupus causes can really lead to effective treatment. So be aware that you can have both lupus as well as non-lupus causes of fatigue. So now we explored non-lupus causes of fatigue. But then if we exclude non-lupus causes, really what is the relationship between fatigue and lupus? Next slide, please. So the question here, is fatigue associated with inflammation? Next slide. So what's the relationship between fatigue and inflammation? So it's intuitive, and traditional assumptions are that fatigue is associated with inflammation. And that's partially the case. And fatigue, for example, can infrequently be associated with disease flares. But as we heard in the prior talk, in a lot of cases, fatigue is not primarily associated with disease activity or inflammation. And this is really important to emphasize, that often it's not associated with disease activity and inflammation. So for example, fatigue is associated with non-inflammatory disorders such as fibromyalgia and brain fog, emotional health concerns such as anxiety or depression. So it's helpful to understand what we mean by the concepts of type 1 and type 2 lupus. Next slide, please. So fatigue is what we call associated more with type 2 as opposed to type 1 lupus. And I hope this table illustrates that point. So in the rightmost column, you'll see type 2 lupus. And type 2 lupus is usually not associated with active lupus inflammation. In type 1 lupus, there's usually evidence of more disease inflammation. So if we think about fatigue in the first row, it's typically more associated with type 2 as opposed to type 1 lupus, non-inflammation. Now, in contrast, you see active inflammation is associated more type 1 than type 2 lupus. So evidence of organ inflammation, again, is going to be seen more frequently in type 1 as opposed to type 2 lupus. And examples of organ inflammation that you might see in type 1 lupus, for example, can include rash and arthritis, mouth sores, pleuritic chest pain, and kidney disease. Next slide, please. So instead, there's lots of different disorders that you see with pain that are associated with type 2 as opposed to type 1 lupus. So example, for fatigue, associated with type 2 lupus, non-inflammation as opposed to type 1 lupus. Depression, associated with type 2 lupus, non-inflammation, and not type 1 lupus. Similarly, anxiety is associated with type 2 lupus. Fibromyalgia and chronic pain is associated with type 2 lupus. And brain fog is also associated more with type 2 as opposed to type 1 lupus. Next slide, please. And again, we mentioned this on the prior slide, but I'll just emphasize this about fibromyalgia really being so much more than a chronic pain disorder, and again, associated with type 2 as opposed to type 1 lupus. Next slide, please. So here's the take-home point with the third part of this talk, is that fatigue is usually not associated with active disease inflammation. So it can be infrequently associated with inflammation, such as disease flares, but instead fatigue is usually associated with type 2 disease, not associated with inflammation. And so this suggests that treatment of type 2 disease, mood disorders, pain, sleep disturbances, it can help with the treatment of fatigue. Next slide, please. So now we arrived at step 4, which I'm particularly excited to talk about. So what are some medicinal as well as non-medication approaches that I use to treat fatigue in lupus? Next slide, please. So first of all, as we mentioned beforehand, we always need to consider and treat non-lupus causes of fatigue. So if identify, that means treating hypothyroidism, limiting the use or dosage of medications that could cause fatigue, such as sedatives, treating anemia that's not due to lupus, such as iron deficiency anemia, and finally, treating vitamin D deficiency. And the blood test that we use, it's a 25-hydroxy vitamin D, and your physician should be doing this. And you want to target levels to about between 40 and 50. Next slide, please. So again, there's a limited role of immunotherapy when we come to the treatment of lupus fatigue. So hydroxychloroquine can be helpful, and all lupus patients should be on hydroxychloroquine. But corticosteroids and immunosuppression will only help if fatigue is associated with inflammation. We saw that that's infrequently. So in most cases, management of fatigue is non-inflammatory and does not require medications that suppress your immune system. That's a good thing. So it involves treating chronic pain, fibromyalgia, promoting emotional health, optimizing sleep, obtaining sufficient exercise, and having a healthy diet. Next slide, please. So again, when we talk about treatment of fibromyalgia, we want to optimize sleep, exercise. You could use techniques such as meditation. There are different medications that could be used, and some examples, you shouldn't try to memorize this, are amitriptyline, duloxetine, gabapentin, and pregabalin. But the more relevant point is that when it comes to fibromyalgia treatment, is discussing with your physician when to start medications and which medications might be optimal for you. Next slide, please. So taking charge of your emotional health is key. So I find that in visits like anxiety or depression is often deprioritized, but it actually should be coming at the forefront of the visit. Now, depression causes features that is just as broad as lupus complications. So depression is much more than sadness. Patients can have appetite changes, poor sleep, withdraw from family support, withdraw from activities that bring you pleasure. So depression hurts. So you really want to avoid the stigma that fatigue is, quote, not real or, quote, in your head. And really, if you avoid the stigma, treatment that improves your emotional health can greatly improve your fatigue. Next slide, please. So starting tonight, you can help your fatigue with the following strategies. So you want to try to get at least 8 hours of sleep per night. And this is really important. And I find it challenging with my kids, but at least 1 hour before bed, we go around, we try to limit activities that can cause suboptimal sleep. And you want to promote a healthy sleep-wake cycle, otherwise known as a circadian rhythm. So within an hour of going to sleep, turn off the cell phones, television, and laptops. You want to try to avoid caffeine after lunch. If you can identify, preserve sleep-promoting activities such as reading, warm baths, practicing yoga if you learn that, or meditation. Sleep apnea is really important to consider and identify. And I've seen dramatic improvements in patients diagnosed with sleep apnea when optimally treated. Their fatigue could get significantly better. Next slide, please. So what about exercise? Exercise is important because it can contribute to weight loss, can help treat depression and anxiety, can help treat brain fog, and ensure healthy diet. Greatly improve your fatigue. So you want to start by being conservative. You could start taking walks or running. If there's a preferred location that you might enjoy, such as a nature trail, that's ideal. If you have joint pain, water aerobics or swimming, the water can be soothing. It can promote a whole body workout. It can be used, again, if you have joint pain. And then over time, you want to aim for 20 to 30 minutes a day. And you want to try to establish having what we call an aerobic workout. And so that could be considered as increasing your heart rate so you become a little bit sweaty. And you should consult with your physician beforehand if you have concerns of heart or lung disease. Next slide, please. So what about some dietary strategies that I've used with my patients? So you want to limit intake of red meat and food that's highly processed, fried, or salty. You want to increase intake of foods that are likely anti-inflammatory and can help manage fatigue. So make sure you have enough fruits and vegetables that have a broad range of colors. Some examples can include berries, grapes, cherries, citrus fruits, leafy greens such as kale, spinach, or collards, broccoli or mushrooms. Foods that are rich in omega-3 fatty acids are likely anti-inflammatory and can help with your fatigue over time. So this includes fish such as salmon or tuna, nuts such as walnuts, seeds, flax seeds are good, as well as vegetable oils. Next slide, please. So here the take-home points of this talk is that fatigue can stem from non-lupus causes. So always, always, always consider causes of fatigue other than lupus. All patients should be on hydroxychloroquine and should have adequate vitamin D levels. There's a limited role for immunotherapy, immunosuppressive therapy, since fatigue is usually associated with non-inflammatory causes. Remember the concept of type 2 lupus, and therefore, strategies that don't use medications, do not need to depend upon medications, have a very important role. So I really think that starting tomorrow, you could be on your journey towards limiting your fatigue in terms of trying to figure out how you could promote your emotional health, adopting better sleep hygiene, obtaining sufficient exercise, and having a healthy diet. So next slide, please. So what I find really fascinating is that if you understand lupus fatigue, you can understand certain connections with fatigue and other autoimmune diseases. And this is because lupus fatigue is fascinatingly relevant to other autoimmune diseases. So for example, we see how fatigue is also very frequent in patients with Sjogren's disease or rheumatoid arthritis. But just like we saw in lupus, just as fatigue is not primarily associated with inflammation, fatigue and rheumatoid arthritis is also not associated with inflammation and can stem from causes such as fibromyalgia, brain fog, and depression. And what this means is, and you could share this if you have a friend or a family relative with another autoimmune disorder, is the strategies that you heard tonight in terms of managing fatigue and lupus are highly effective in any autoimmune disorder. So feel free to share this with patients or loved ones who have autoimmune disorders other than lupus. Last slide, please. So I just want to really talk about the book that I authored. It's called Living Well with Autoimmune Diseases, a Rheumatologist's Guide to Taking Charge of Your Health. So the the book includes chapters on lupus, but there's chapters on Sjogren's disease and vasculitis, rheumatoid arthritis, psoriatic arthritis, scleroderma, and myositis. And I think this is important because autoimmune diseases are interconnected in so many different ways. So the way I think about this is that there's no autoimmune diseases on the island. And that's why I think that the strategies that you learned about tonight with fatigue can help with other autoimmune disorders. I've included chapters on wellness, including strategies dealing with fibromyalgia, depression, and diet. If there's one unifying theme of this talk that I feel very passionate about, it's about patient empowerment. And I talk about different self-empowerment strategies that you could use, that you could bring to your illness. And you could explore this further at juliusbirnbaum.com. So again, I want to thank the Lupus Foundation for the opportunity, and hopefully you found these strategies useful.
Thank you so much, Dr. Birnbaum, for sharing this wealth of information. Thank you so much. And now I'll open the floor to our panelists. We've gotten some questions that were submitted to us, although most of these questions have been answered throughout the presentations, but I'd like to highlight a few. One of the questions here is, what are the strategies for explaining pain or pain level to healthcare providers?
You want to start, Julius, or do you want me to?
Oh, that's pain. I'll leave this to you. Yes, sir.
Well, how do I say this? Try to explain, not complain. Try to really tell like what's the character of your pain, what seems to make it better, what seems to make it worse. That's the kind of information that it really is helpful clinically. And also make sure you tell your providers about pain you're having in places of the body other than where your chief complaint is. One of the biggest things that we can use to see whether pain is more like type 2 or fibromyalgia pain is it's multifocal. It's in a number of different areas. And if you don't specifically give someone like a body map to fill out to see where all the places they're having pain, or if someone doesn't tell you that, you don't necessarily pick up on that. You just focus on the region of the body that they might be, coming in for that visit with pain in. So it is important to tell about all the different sort of places that you're having pain. But again, remember that that anyone, if physicians included, would rather that you explain that than just complain to them.
No, I agree. And to apply that for the treatment of fatigue, what I think is that, and I find this fascinating, is that I hear a lot of patients struggle their fatigue. And what happens sometimes is this incredible lyricism of patient metaphors that come at the forefront. So, for example, someone said, like, I feel like I ran a marathon through the Sahara Desert, or I feel like someone's taking a hammer and hammering on my bones. And I think that what's important is that you should have enough conviction and courage that however you describe your pain and fatigue, you do it in a way that's very rich. And I think trusting your own gut and bringing your own set of convictions and how you use language to an appointment really helps convey your symptoms very vividly to your physicians.
The other suggestion I would have, because we are learning to focus more and more on this in pain management, is to focus on like one or two things that functionally you can't do that you'd like to be able to do, and that actually is helpful to set treatment goals and to motivate you to use some of these non-drug therapies. Is instead of like focusing on the pain itself, focus on like what is the pain not enabling me to do, and what strategies might I be able to use so that I could do those things again.
Thank you so much for answering this question. I believe this question resonates for a lot of people in this event tonight. Another question we have is, how do you get your providers to believe you when you are fatigued or in pain and actually do something for you?
Yeah, I agree with Dr. Clauw. I just find it so helpful to focus on, how the fatigue is affecting you when it comes to your function. Especially this applies to newer follow-up because you have to recognize that your physician is seeing maybe a lot of 20 other patients that day, and maybe you have 15 minutes with them. So I actually recommend that you practice beforehand. It's very important that you're efficient. And the best way to be efficient is to practice your visit beforehand. So pretend that you're having a visit with a physician. You could, ask a friend or family member and start practicing the beginning of the visit. And I think that if you do that, that's a strategy to make sure that your complaints are prioritized in a way that makes sense for you and that could be conveyed to your physician.
Yes, I can't agree more. Practice makes perfect. So it's always a good idea to practice before going to your physician. Another question we have here is regarding fatigue and inflammation. I find that my fatigue is mostly when my joints are hurting. Is that like joint pain and fatigue are related somehow? Is this incorrect?
Well, when it comes to fatigue, and this is, obviously Dr. Clark can speak to this very well, but it's important to understand, like, if is the joint pain, is it occurring in the context of more of a pain syndrome such as fibromyalgia, or is it joint pain from inflammatory arthritis? Now, I think that for the most part, if the fatigue that's due to joint pain from inflammatory arthritis, that has an easier on-off switch. So if there's a flare, for example, and you have some increased fatigue, then you could treat that with a shot of intramuscular Kenalog, and that'll help. And that's a way of knowing if it's due to inflammation. But I think a lot of times the more broader focus is to try to understand whether what you're experiencing is joint pain, which is active disease, or whether you're experiencing a more diffuse pain syndrome, such as fibromyalgia. And again, the clues are if you have a lot of pain and it's associated with type 2 lupus features, such as brain fog and depression, mood disorders, then that's a key that non-medicinal approaches will be the better choice for you.
Thank you.
And pain location can be really helpful in telling what what your pain seems to be driven by. Lupus is a little bit unusual for autoimmune diseases because it affects a lot of, but often the pain is in like the small joints of the hand if there's active lupus. There's but it's not, the active lupus doesn't involve like the trunk, like the back, the neck, and things like that, and that's much more likely to be, or in the upper arms. We've shown in studies that if people have pain in the upper arms or the upper legs, that's almost always fibromyalgia pain, because like there's no autoimmune diseases that really cause inflammation in those regions of the body. And so the location, when you see that, and also the company that it keeps, if you see that your fatigue and your pain and your sleep problems and your memory problems are all moving like up and down together, that's much more likely to be the type 2 kind of problem that we've been talking about, or the fibromyalgia-like problem.
Thank you. Thank you for answering that. And this brings us to another question, which might be related. Is it possible to have both type 1 with inflammation in the body and type 2?
Yeah,
Yeah.
and to a certain extent, this distinction is admittedly some arbitrarily simple. For example, so we use the type 1, type 2 as concepts. Now, lupus is such a complex disease that to say that you have type 1 or type 2 and try to pigeonhole you into a specific category is not going to work in a lot of circumstances. So you can certainly, for example, have active disease or active joint pain or rash or oral ulcers, and you can also be experiencing type 2 symptoms, which is fibromyalgia. So both can happen. But I think the relevant point is that a lot of patients will have pain and fatigue not associated with inflammation. And that's where these concepts are useful. they're meant to emphasize to a certain extent that there is this type 2 construct where you can have a lot of fatigue, you can have a lot of pain, and not being associated with inflammation. So to be sure, you could have both features of inflammatory and non-inflammatory features, but just keep in mind that these are some conceptual distinctions that are sometimes overly simplified, and it's there more to demonstrate certain relationships rather than is to show that this is absolute science.
And it's also the case that a given individual shouldn't think of their lupus either being type 1 or type 2, because most people that have type 2 lupus had at one point in their life, they did have active lupus. They did have type 1. So it's more so that over time, what we see in a lot of pain syndromes is over time, it starts out as more of a, it's that all of the pain is driven by active inflammation early in the disease, but as people have the condition longer, then a lot of times you see the pain, the fatigue, and things like that is totally independent of the inflammation. And that's important for people to understand, because the drugs we use to treat the inflammation are not benign drugs. They have a lot of side effects and toxicity and things like that. So you don't want to be treating type 2 lupus with really powerful biologics and immunosuppressives that carry significant side effects.
Okay. Thank you. Thank you. And another question we have here is, does fatigue ever go away completely? And can exercise help with my fatigue?
So yeah, absolutely. Exercise can help with the fatigue. And, you know, it's important. I think that a long-term goal is to get you to have an aerobic workout. And again, like I talked about, that's 20 to 30 minutes, making you feel sweaty. But I find that a lot of lupus patients with fatigue, they're really not physically active at all. And there's this certain barrier that has to be surmounted. It's very hard to go from a sedentary lifestyle to one that starts incorporating physical activity. And that's why just the littlest things you could do. I mean, just try going for a 5-minute walk a day, or if you're a gym, like don't worry about water aerobics, just like submerge yourself in the pool and just enjoy the buoyancy and warmth of water. So, you know, going down that exercise route can be enormously helpful. It's just take things slow at once, and then you can build up and you'll be surprised at how much you can enjoy it. And then, yeah, fatigue it can be greatly improved. And again, I want to emphasize all the wellness strategies and really this vast array of options that you have to treat fatigue that, like Dr. Clauw says, does not depend upon these immunosuppressive medications, which could have like a lot of side effects. So if it's not necessary, don't go there.
I stopped using the word exercise a long time ago when I talk to patients. I use the word activity because I think that it's just helpful to get people started moving. So I think that if people focus on becoming more and more active at some level, that increased activity might reach a threshold where we call that exercise. But the data show that, and again, I think most of us that are humans learned this during COVID when we were like cooped up and we weren't active and we couldn't move. Everyone got tired. Everyone got like a mild case of fibromyalgia. And so that is, you know, just something that is human nature. And so really just try by becoming more active and moving, rather than saying, oh, exercise, that's like too much and I can't do that.
I agree. Gradual progress. So another question is, are there current studies being done on any new medications or possible pain control methods?
Yeah, there's a lot of active work in, you know, in the pain field, and certainly a lot of biologics are being developed. We're really learning, you know, more and more. And again, a lot of the drugs that we both talked about that can be used in this kind of pain, drugs like duloxetine or drugs like cyclobenzaprine at bedtime, can actually help a lot with the fatigue. Some of those drugs are particularly helpful with fatigue, but um, again, it's more, you're treating more than central nervous system neurotransmitters rather than, active inflammation using those drugs.
Yeah, and the one thing and certainly like there's this there's a lot of new medications that are biologics, but again, I think that a lot of times there's this understandable inclination to understand with regard to medications what's new and what's on the horizon and what's being developed, because that gives you a sense of hopefulness and optimism. And what I try to emphasize in patients, or what I try to emphasize in the book, is that yes, there are medications that can go there, and it's certainly on the horizon, but there's so much more that you can do that you haven't tried yet that doesn't involve medications. And I think that there's almost a stigma if you say to somebody, oh, your pain is in your head, or or fatigue is in your head. It's real, and you have the capability to manage fatigue or pain with all these strategies that don't involve medication. So yes, I think new medications are important, but you actually have the power to change your fatigue or pain just by thinking about non-medicinal strategies that you could use.
Thank you so much. Another question is, because of my extreme fatigue, I feel unproductive during the day and struggle to complete everything I need to do. My face looks very tired. I no longer approach tasks with the same productivity I used to, and I experience frequent migraines. Could the migraines be also related to the fatigue?
Yeah, well, I mean, as a neurologist, I could say that migraines are very common, and everyone has migraine triggers. Certainly, like poor sleep, which could be associated with fatigue, can be associated with migraine. So, and then you have migraines as a headache syndrome that could go along with fatigue. So I think that if you have like migraines, there are certain strategies that you take, but sleep hygiene is really, really important. So taking steps so you get better night's sleep, and remember, an hour before bedtime, turn everything off. Try not to indulge in things that'll get you too excited. Sleep hygiene is really important in migraines, and it's really important in sleep.
Thank you so much. Another question is, my wife has lupus type 2, and she is fatigued with foot pain. How can I help her?
So fatigue with foot pain?
Yes.
Yeah, so that's a good question. So the question then becomes like, what type of foot pain, is she experiencing? And for example, it's if I'm hearing that one thing that I'm thinking about is the foot pain. Does it have a burning, tingling quality? Is it neuropathy? And so it's important to try to identify like what exactly is the underlying cause of foot pain. Neuropathies, it's interesting, in Sjogren's can be associated with less active disease, and we've shown that neuropathies can be associated with non-active lupus, and so it's kind of a chicken and the egg story. But definitely, whatever the cause of her, if she does have a neuropathy, that could also be the cause of fatigue. And there are certain medications that you could talk about with your physician that are helpful in treating neuropathic pain and also with fatigue.
Thank you. Thank you. Another one here is, are there any labs to definitely tell between type 1 and type 2 lupus?
Oh.
Yeah, there's labs that are used by your rheumatologist. There's no single lab test that is always up when people have inflammation, but there's a series of tests that your rheumatologist will do to see if it looks like your inflammation is more active or not. It's not a definitive, and there's no test you can do like to diagnose, for example, fibromyalgia. There's no blood test or anything to say, yes, this is type 2 or that this is fibromyalgia. It's almost the absence of inflammation that would make you think that that's what the problem is.
Yeah, and I think that's a great question. And I think the surprising finding of this, there's certain labs that we think about in lupus, for example, is associated with more inflammation. And this is the point I was bringing towards, you can also see this with Sjogren's as well as rheumatoid arthritis. So for example, we typically think of as Sjogren's, there's an antibody called anti-Ro antibody, and that's associated with inflammation. And we typically see that Sjogren's patients with pain tend to have lower levels of this antibody, anti-Ro antibodies. And it's likely that lupus patients with pain or fatigue have lower levels of these antibodies that's typically associated with inflammation, such as anti-double-strand DNA antibodies. So it's a really interesting story about why fatigue, not just in lupus, but with other autoimmune diseases, it tends to be associated with lower level markers of inflammation that you could check for on your blood work.
Thank you. Thank you for answering that question. And we have another question here, someone asking, I find it that if I lift weights, even small, I tend to start flaring up in pain. Should someone avoid strength training exercises?
I would just be careful of the types of exercise, the order to do them. Again, to first just try to become more active, then stretching, moving towards aerobic. Strength training is something that you just have to be careful with. Use very light weights, go up very slowly. It's probably the only kind of exercise that people, like if they're not careful, are going to hurt themselves with, whereas becoming more active, the other kinds of things we're talking about almost always make people better, not worse.
Thank you. Thank you. Such valuable information. Another question here is, what are your thoughts on ablation for pain, killing the nerves to stop pain?
If the pain's, I answered that, if the pain's coming from the nerves, ablation works. The trick is often trying to figure out if that's in any way the source of the pain. There's certainly a lot of nerve ablations and things like that are done in the United States that don't help the person whatsoever. And just in general, spinal procedures and things like that don't work nearly as well as they're sort of purported to work. And they help some people, but again, they're used a lot more often than probably they should be used, given how effective they are overall.
Thank you so much. And another question here is, what kind of recommendation do you have for night routine for fatigue?
Yeah, well, this is what we talked about, and I could tell you as the father of three kids, there's just chaos at night. And so the nighttime routine is really important. You have to, everyone's different. And the really important thing is to have like an hour before you bed. And I say an hour, it really has to be like sacrosanct. And it actually takes a lot of practice because we're constantly bombarded by stimuli. We come home, we want to relax, we want to turn on the TV, we're almost assaulted because we have these 50-inch screens. I mean, you can imagine like 50, 100 years ago, like when it was night, and your body knew that there were circadian rhythms that it had to listen to. And what happens, with modernity is that that circadian rhythm is lost. So it's really important to really practice getting into a sleep hygiene state. So that hour before your bed, you're focusing on, going back to where humans were, 200,000 years ago. And night was night. Night means darkness. Night means it's time to shut your things down. And so really adopting a sleep routine that lets your body know biologically that you're going to sleep is really, really important.
Thank you. Thank you so much. And I think I saved the last question, the most popular question that we got. The question is, can you suffer from fatigue and pain even when not in a flare?
Yeah, I mean, I
Yeah, I
think
think that's what we've both been saying all night, is that don't assume that when you have pain and fatigue, it's because of a flare, i.e. a inflammatory flare of your lupus.
And I think this brings us to the end of our question and answer session. We got a lot of questions, which we will make sure to respond to. We'll receive these questions from our health educators, and you can reach the Lupus Foundation of America via phone, email, website, Facebook, Twitter, and Instagram. Again, thank you, Dr. Birnbaum, and thank you, Dr. Clauw, for honoring our invitation tonight. Thank you. We appreciate
Thanks for
you.
having me.
Yeah, thank you. Thanks.
Thank you. And we do have a survey. You can please hover over your camera phone over the QR code to get an access to the survey. And 2 people will be selected at random to receive LFA swag after completing our survey. The survey closes April 30th. Thank you so much, everyone, for joining us tonight. Thank you. It's an honor to have you all.